Yeah, fine. It says co-director clinical strategy. My other half, in the non-marital sense, don't get that idea, is Martin Lombard sitting there in the second row asking the difficult questions in the first session. And he won't be asking any this session now. I hope. Yes, it says clinical co-director clinical strategy. Actually, as you might have guessed, because I'm wearing cords, I'm actually a GP. You may have thought geography teacher, but they have leather elbow patches on account of not being able to afford new jackets. And that's the title I picked, not for any reason, just thought it was a really nice thing to stick up. This is the title I should have given, which is the gaps in big data. And it is a strategic NHS perspective, so stay awake and you'll pick the jokes up as they go along. I'm just very aware of where I'm standing. I don't really want to stand so it says colon, just if my head's in the way. Okay, just so you know, rather like Simon, it kind of helps to know where I'm coming from if you know where I've been. Yes, still a GP, see patients 2 days a week. I've got made up a job title to work at Aintree because I used to work for them a lot and now I just do 1 day a week, so I'm a SPAD with them. This gig, I've been involved in informatics for ages and ages and ages, but not as long as I've been the medical advisor at the Philharmonic in Liverpool, which is much more fun. Past jobs, PCT medical director, yeah. My claim to fame, and it's the thing I'll have on my tombstone when I die, was that in 2000 we introduced an intranet in St Helens and Knowsley. And it had 3 components. It had web communities that you could join, it had an archive of deposited information which you could put stuff into, and it had these things that we called people pages, which were pages that people could use to edit and write about themselves. And we launched that in 2001, whatever. If we'd have called it Facebook and done it 2 years later, I wouldn't be here today. Yeah, and then kind of that's my matrix moment. I unplugged from the NHS and went doing a master's in health informatics, and it all went wrong because up to then I thought the NHS was pretty good. I thought it had the best healthcare system in Europe. I thought it really knew what it was doing. And everything else since then has been proving to me that we stumble past on the will of, well, the government makes it up as it goes along. But let's be careful. Not wishing to sound like Hill Street Blues, and everybody here is old enough for Hill Street Blues, jolly good. Let's be careful out there. The Gartner hype cycle, we're all familiar with this. This is the reason why in my practice we only had 1 patient on rosiglitazone when it got withdrawn. New drug comes out, it's the best thing since sliced bread, then you find out what goes wrong and then you find out where you should use it. That's the medical side of it, but it works for everything. And here we are with big data. It's probably, according to them, got 2 to 5 years before it peaks and starts rocketing down into the trough, before everybody says it's a waste of time and a waste of money. So we, LBDC, might actually be just coming to the crest and getting on the bus a little too late. Come on. Who knows? I mean, you know, what can I say? Somebody had to say it. Everybody's done big data sizing and everything, location, wooden trees type stuff. The last time I spoke to a proper IT person, he said, you keep saying big data, but what do you mean by that? And I gave him that definition, and he went, it's very computer science, but yeah. That was a thoroughly pissed off IT guy, which was great.
Wasn't me.
Fortunately, it wasn't. Yeah, and that's kind of like Simon's thing about if you know what your question is, you probably shouldn't be looking for a big data answer. If you don't know what your question is, then it's probably a big data thing. And yet, we mentioned about this, the bigness of it, the fact it's 20 exabytes worldwide and all that kind of stuff, just rocking and rolling, yeah, fine. I'm a simple soul and not quite into binary, but I kind of think, well, we've got 2 choices with everything here. What are you going to use this for? Where's it come from? I thought the first law of informatics was that information was fit for the purpose for which it's entered. Okay. And the part 2 to that is if you're going to use it for something else, make sure you do it with the consent, knowledge and support of the people who entered it in the first place. You might have to think about that when it comes to big-ish data. So, are you using it for individual patient records, or are you using it to plan healthcare in Merseyside? Have you got it all in one place, or are you going to have to go and beg for it? Pull it up out of other things. And who is it about? Is it the individual, or is it the population that you're kind of looking at? And just simply putting those things together, you get this cube, which I just made up because I was bored, which puts each of those dimensions out. Okay. And it kind of makes sense, yeah, it's either one or the other, you know, operational or strategic, multiple personal stay the same, yep, fine. Personal or population, yep, fine, that's good. And then I thought, well, what have we got knocking around the NHS at the moment? And I can find bits and pieces that fit in everything apart from these bits at the back. Now, I was really heartened to hear everybody today basically saying it is about how either we as commissioners, the healthcare system, the NHS, or as my son calls them, the NHSs, how they work in long-term, population-based, strategic, and it's all in multiple different databases. Well, surely be to goodness, that's a great place for big data to work. Equally, down the bottom bit here, that's about how I know what I'm going to be like and how I can make best use of my health, such as it is up until 2040. Come back to that. But it does kind of pose big questions to us about this. I mean, you know, today feels very much like we're of a mind, but then we would be because some of us are the geeks and some of us are the nerds and most of us are the techies. So we're probably already believers in this as a concept. But we're going to have to do some big sells to get it moving to other people. What's currently out there, Simon's done a lot of that. That's state of the art in terms of big data. Certainly the guys from Aridhia are what's currently out there. What question are we not answering? 28-day readmission, to be honest, nice, good idea. I can see the financial relevance and I'm going to support that because it's a good use case. First step, get that one, absolutely. But what about admission risks, PAR type tools? Yep, fine, they're out there, but okay, what about pre-admission risks? What can I do now to change? By being as overweight as I am, I've got twice the chance of bowel cancer than some of the slim people in the audience. But what does that mean? What does that mean for me? How do I handle that? And if somebody did my genomics and turned up with a really interesting idea that I'm going to die of any of the illnesses my parents or grandparents have had, what am I going to do with that? How's that going to work for me as an individual? So that personal strategic health management, how you put that actuarial approach into my life and make it work for me is a bit of a challenge. And I kind of think of it like that. Can we actually believe the weathermen? Don't worry, madam, there isn't a gale on the way. Is it going to really, really rain heavily COPD on Merseyside? Given that out in Knowsley they've got the highest quit rate for smoking cessation in the country, either #1 or #2, depending on which quarter you're looking at, are we looking at a cessation of the rain in COPD in Knowsley? What's going to happen here in Liverpool? Can we forecast our ill health? And if we can do that, can we change the way the systems provide healthcare? And I totally agree with the wellness agenda. If we don't move into the wellness agenda, if we stop being a national illness service and can become a national health service, we've made it. If we're stuck in ill health management, we're pretty well stuffed. So, big data problems, that's just a nice way of saying that if you know what your answer is, you shouldn't be asking the question in big data terms. Scientists love asking questions to which they know the answer. Which of these two things produces a better outcome? Can you see what they did there? They're assuming a better outcome and there's going to be one or the other. Yes. Big data is a different ballgame. It's going to mean that some of our scientific colleagues who really love the scientific method are going to have to think differently about what they do. And even worse than that, as commissioners and general practitioners and healthcare practitioners, we're going to have to think differently about how we handle the information. Well, I used to practice in Rainhill, which is a nice leafy suburb, live there still. Lots of doctors, nurses on my list, it was great. And then I went back to the training practice I worked at as a registrar. And I thought, these patients in Kirby deserve no less than the guys in Rainhill. I will practice the same standard of medicine. Pre-internet days, you know, there's only CompuServe back then. And so I whipped out my detailed cross-section of this lady's pelvis. And I started to explain, you're laughing because we had this conversation at dinner time. Whipped out this cross-section aid and started to explain about what was going wrong with her, and she looked me in the eye and said, "Save your breath, doc, thick as pig shit." It was only afterwards a friend of mine said, "Did she mean you?" But no, what she was telling me was that actually she did not think herself worthy of any input of information at all at that time. Now I still get a lot of patients who say, "Thank you for your time," as if somehow it's a gift. What I love is the growth, and it is almost exponential, in the number of patients who are coming in saying, "I've read this, found this, been told that, heard this, thinking about this," or even worse in my own practice. I was in seeing Dr. X last week, I didn't really get it. Could you just tell me? Now, there's a heck of a lot more of that going on. So I'm quite happy to be an information broker. I just need some of those tools to help me broker the information in a way that's meaningful and based on more than, Simon mentioned about inference and what was that, concepts. What was that thing he said about? Sentiment, yeah. So I know that when on patient X, the letter comes back saying, thank you for sending me this delightful man. What they mean is, you bastard. Okay. Equally, I know when the letter comes back from patient Y and they say, I really enjoyed talking with this delightful lady in clinic today. What they mean is, how do you shut her up and do it in 10 minutes? Sentiment, it's going to be great fun. So, simply put, my conclusion, because I'm a simple soul, is that big data is going to solve us two problems: population strategic health management and personal strategic health management. It better had, because CDC are betting on it. They want social media to predict flu. Great, why not? And there's a competition on for it. Isn't that good? I love the idea of competition. That means you can say that these people wanted to do that anyway, and we just happened to tap into the zeitgeist and give them a prize for doing it. Personal strategic health management has to stop being that. Okay, I mentioned 2040. Yeah, so 7th of September. Fingers crossed. It's going to be a bit tricky. I might see you then. I may not. I'm thinking of having a party on the 8th of September, but or not. And look at that. Bloody hell, 75 years, 10 months. It's my dad's age. What am I doing here? Actually, I'm fulfilling the prophecy that says that this generation will die younger than the one before. Who knows? But maybe I won't. Maybe the fact I did a 5-mile run this morning, which this site does not care about, maybe that makes a difference. Maybe the fact that I lost a shed load of weight in recent times, which this site does not care about, makes a difference. Maybe the fact that I take my blood pressure, etc., which this site does not know about, makes a shed load of difference. And maybe the Big Data Collaborative can help me make that an awful lot bigger number. But it's not just me, despite anything I may think. This is interesting. I picked up this one off Twitter the other day. Somebody tweeted about it. It's a nice idea. Basically, it says you walk around with your smartphone for a bit, it knows whether you've got Parkinson's or not. How cool is that? Think of that in a big data context. If we use the telecoms providers, would we now know where our Parkinson's patients were at this moment in time and were going to be? Because there's work done in big data telecoms which suggests that after 6 months of following your data, you know exactly, well, 90+% certainty where somebody is at any given moment in time. Today's an odd one for me, but you could have predicted on Monday I'd be somewhere in Liverpool, because I normally am. It's the way it works. You could have got it down to university, because that's where I normally am most Mondays. So do that and do a motion detector on me. Check me out. I don't know. It's an awful lot bigger than we think, I think. If my app goes off and it says, you know, we notice you're a bit slow today, what's it going to do? Is it going to tell me, press the button, call your primary care provider? I ran my own GP last week and they said that they could speak to me in 4 days' time, which I thought was really good. My practice would like to be able to say, we'll ring you back within 90 minutes and see and treat within 4 hours, which is only what A&Es do anyway. But we need to do that. If we put it on a map, and if we were commissioners, for instance, and some of us are, and we knew where this cluster of patients was, would it change where we built our primary care centres? Almost certainly. Would it alter how we chose to treat hard-to-reach groups, who, by the way, are not hard to reach if you go to where they happen to be? It's all about perspective. It probably would. And if anybody's going to do it, I think LBDC will be the place to do it. There you go. Thank you very much.